Yes, ma'am.
Okay, so if you've read and understood, considering it critical care scenario, please tell me how would you manage this patient now?
I will manage the patient according to ATLS protocol, and I will go for ABCD approach. At first, I will check for airway if that is patent, and if patients and I will manage the airway accordingly, and then I will go for breathing, and I will give supplemental oxygen, and I will check the respiratory rate as well as oxygen saturation.
Okay,
And I
I'm
will
sorry. I have to stop you for a second. A is not complete. First, because this is what type of case it is. You'll manage it according to ATLS protocol, right? So
yes,
in ATLS, first airway and then
breathing,
no, this is ATLS protocol. Airway and then
external hemorrhage.
no, come on, think.
Oh,
Af-
cervical spine, yeah,
yes.
and
What
immobilization
you
of
will do?
cervical spine
Yes. With what?
with sandbag
And
or tape or hard cervical collar.
yes, three things. All right. Now moving on to breathing. Yes. Yes.
Yes.
Continue, please.
And after breathing, I will go for careful monitoring of circulation.
Okay.
And specifically for this patient, I will carefully check the GCS. And
No
as
abbreviation.
patients,
What is GCS?
Glasgow Coma Scale.
Yes.
As these patients' current Glasgow Coma Scale is 8, I
Yes.
will consider intratracheal intubation for this patient.
Very
Um,
good. Okay.
and then I will go for exposure. And
All right.
subsequently, if patient is hemodynamically stable, I will arrange a CT scan of it.
Can you please tell me why patient's Glasgow Coma scale dropped from 15 to 8?
This may be a lucid interval,
Okay. What is
where
lucid interval?
initially there is an amnesic event, and subsequently an improvement due to recovery from the cerebral concussion, and subsequently a patient will deteriorate, and there will be fall of Glasgow Coma Scale due to accumulation of blood within the extradural space.
Okay. Why do you think patient might have had amnesic events?
Patient might have cerebral concussion.
Okay.
That may be a reason.
What is the normal intracranial pressure?
A normal pressure in spine position 7 to 15 millimeter mercury, and in standing position 10 millimeter mercury.
According to the NICE guidelines, when would you ask for CT head?
There are some high risk factors and some moderate risk factor. High risk factor, like if patients GCS fall less than 15 within 2 hours post event or post injury, if 2 or more episodes of vomiting is there, and if patient has suspected open or depressed skull fracture, if patient has any signs of basal skull fracture, like Rekunzai battle sign, or hemotympanum CSF rhinorrhea, autorhinorrhea. And if patient's age more than 65, and if patient is anticoagulated patient. And some moderate risk factors are there, like if patient is amnesic for more 2 event, 30 minutes or more, and if a patient has dangerous mechanism of injury, like if patient is stuck off by a motor vehicle, or ejected from a motor vehicle, or fall from height more than 3 feet or more than 5 stairs.
Okay, can you please tell me what is Cushing reflex?
Cushing reflex is the neurological response to increased ICP, increased intracranial pressure. It is due to mixed vagal and sympathetic response to increase intracranial pressure. There will be Cushing's triad, that is increased systolic blood pressure and wide pulse pressure, as well as bradycardia and irregular breathing.
Okay, what is Monro-Kelly hypothesis?
It's a hypothesis that denotes that skull is a fixed box containing three components: brain, blood, and cerebrospinal fluid. And increase in the volume of one component will lead to decrease in volume of the other components to a certain point. It will be autoregulated. And beyond that, the increase in very small amount of volume of one component will rapidly increase the intracranial pressure.
When would you decide, okay, you said you'll maybe intubate the patient. What, according to the NICE guidelines, when a patient with head injury should be intubated?
Intubated if patient's Glasgow Coma Scale 8 or less, and if a patient needs optimization of oxygenation and ventilation, and due to certain kind of injury, like if a patient has severe facial injury or mandible fracture, or a patient is unable to maintain the airway due to it may be due to loss of protective laryngeal reflex. These are the reasons.
Okay. What are the advantages of intubating the patient?
Advantages will be to maintain the airway, and to maintain the oxygen saturation, as well as to decrease the intracranial, to prevent a rise of intracranial pressure due to agitation or respiratory effort, excessive respiratory effort.
Okay, can you help me and read this image? What is it? First of all, please explain.
This is an axial view of CT scan of head, revealing hypertense, biconvex hypertense shadow on right parietal region with midline shift and compression of ventricles.
Okay, and how would you describe the shape that you're biconvex? And hyperdense, midline shift, and compression of on the ventricles. Okay, what would you do if your patient presents with increased intracranial pressure?
If to decrease intracranial pressure, certain measures I will take, like some conservative measures and surgical measures. Conservative measures. First, I can hyperventilate. I will consider hyperventilation of the patient that will help to decrease the participation of carbon dioxide and give a temporary protective effect by causing cerebral vasoconstriction. And to increase the cerebral venous return, I can consider elevation of the head end of the bed up to 30 degrees. And to decrease the cerebral edema, I will give mannitol. I can also give IV furosemide, and maintains serum sodium 140 to 145 millimolar per liter. And to decrease the I can also give barbiturate. I will also consider barbiturate coma for the cooling effect, to decrease the cerebral edema. And if and I can also consider decrease of basal metabolic rate. If there is seizure, I will give IV phenytoin. And if there's intractable raised ICP, I can consider thiopurine sodium infusion.
If all your medical management fail, what is the last?
I will for surgical measures. I will evacuate hematoma. I can go for a decompressive craniectomy and drainage catheter.
Yes.
Placement of drainage catheter.
All right. Okay. What are the ways by which you can measure intracranial pressure?
There's some invasive and non-invasive measures. Invasive ways are in placing intraventricular catheter, intraparenchymal probe, or lumbar puncture, intracranial intraventricular catheter.
Subdural catheter. Yes.
Subdural
non-invasive ones are?
Non-invasives are tympanic membrane displacement and transcranial Doppler.
Yes. Okay, thank you.